Good evening, everyone. Today I'm going to talk about the additional diagnostic finding on IVR-CT while you perform liver embolization. The Canon Angio-CT hybrid system has been operated in our hospital since 2016. Currently, we perform tests with IVR-CT over 300 cases a year. We also use the system to perform complex vascular procedures and CT-guided non-vascular procedures as well. For liver embolization procedure, the routine procedure consists of CTAP and CTHA. CTAP or CT during arterial portography is performed by placing the catheter in the SMA and scan on the delay phase, while contrast is in SMV and portovein. So the scan image is a pure portovenous enhancement of the liver. CTHA or CT hepatic arteriography is performed by placing the catheter in the hepatic artery and scan in the early phase to show arterial failure and also the tumor enhancement. Then we use the volume data of CTHA to do 3D reconstruction. We can identify the target artery manually, or we can use the EmboPlan software to identify all the feeding arteries. Then we can use the 3D reconstruction image as the imaging guidance in the angio suite. With the single contrast injection of CTHA, then we can display the multiple angio projection from the image and use them for selective catheterization of each branch. At the end of the procedure, non-contrast CT scan was done to see the accumulation and distribution of lipidodal staining within the tumor. So in the routine case of TACE performing with IVR-CT, we will get 3 series of CT images including CTAP, CTHA, and post-TACE scan. We have around 500 cases of TACE a year. Due to resource limitation, we cannot use IVR-CT for every case. For a case that's quite simple and straightforward, such as large tumor or multiple tumors, we will use conventional DSA. IVR-CT is also not suitable in emergency setting and in the patient who cannot cooperate. Among many advantages of IVR-CT, first, I would like to address the impressive diagnostic power of tumor detection and evaluation of vascular invasion and extrahepatic organs. In this case, the diagnostic CT shows a small HCC in right lobe with background of liver cirrhosis. But on CTAP and CTHA, we found another small nodule at caudate lobe, appearing hypoenhancement on CTAP and vivid arterial enhancement on CTHA. This finding compatible with small HCC. With this additional information, we can then perform selective tests for both lesions at the same time. CTHA is very helpful for angiographically undetected small tumor. Identifying the feeding artery on DSA is impossible in such cases. But with CTHA and EmboPlan, you can perform selective tests of several feeding arteries successfully and effectively. This patient has multiple small HCC in both hepatic lobes. The tumors are prominently visualized on primoris delay phase. But on the conventional angiogram, the small HCC are obscured by diffuse nodular enhancement throughout the liver. Again, we can use CTHA compared with MRI primoris to see where the tumors are. Then perform selective tests to each feeding arteries. You can see the results of precise embolization using the CTHA as image guidance. IVR-CT can also help you detect minor vascular invasion. On CTAP, the portal vein tumor thrombus will appear as a filling defect. Another clue is you will see an area of hypoenhancement according to the level of portal vein occlusion, which could be lobar, segmental, or subsegmental level. On CTHA, the portal vein tumor thrombus will show arterial enhancement, which will help you differentiate from vascular thrombosis confidently. Even the small, non-occlusive portal vein tumor thrombus can be clearly seen if you carefully review the image of CTAP. Evidence of vascular invasion is very important for tumor staging. It can change from intermediate stage to an advanced stage, and the prognosis and overall treatment planning might be changed. I would like to show the comparison of CTAP in these two patients. Both of them have large tumor in right lobe with extensive portal vein tumor thrombus. On the first case, the enhancement of left hepatic lobe is well preserved due to abundant cavernous transformation and patency of distal left portal vein. In the second case, the parenchymal enhancement, especially non-tumorous left hepatic lobe, is very poor. This represents much more severe portal flow compromise in this second case as compared to the first one. CTAP can provide additional information of portal flow. In this case, the patient has severe portal hypertension. Most of the blood from SMV does not go to the liver, but shunting via splenic collateral and directly drain into the IVC. Now take a look on the CTAP and CTHA of this patient. This patient initially diagnosed with single HCC, planned for TACE, and then possible for surgical resection. The initial CT scan and the TACE procedure are about 8 weeks apart. So based on CTAP and CTHA image, there are clearly tumor progression with macrovascular invasion. Now the patient has multifocal HCC with the tumor thrombus invading into IVC and right atrium. We decide to go on with the procedure by selective catheterization to each feeding arteries of tumor thrombus and also the tumor area. After the first test, we combine the local regional treatment with external radiation for the tumor thrombus in IVC and right atrium. Until now, the patient has 3 sessions of tests and we can achieve almost complete response of the tumor thrombus and also the tumor in left hepatic lobe. If there are any extrahepatic metastases in the field of view, such as basal lung, adrenal, lymph node, or peritoneum, it can be seen on CTHA and CTAP. But you have to keep in mind that on CTAP and CTHA, most of the extrahepatic metastases will appear hypoenhancement. Unlike the conventional diagnostic CT scan, if the extrahepatic tumor mass does not supply by hepatic artery, SMA, or portal vein, it likely to be hypoenhancement on CTAP and CTHA. But if you perform catheter-directed angiography of the feeding artery, then the tumor mass will show vivid enhancement. The additional information of tumor number, tumor distribution, extension of vascular invasion, and persistence of extrahepatic metastasis altogether may change the tumor staging, overall treatment planning, and definitely change the plan of TACE embolization. The next advantage of IVR-CT is when you perform extrahepatic arterial feeder embolization. IVR-CT can help you identify an unusual branch of feeding arteries. IVR-CT can help you Pick the proper position of microcatheter tips to avoid non-target embolization and also maximize the tumor control effect. Besides the large tumor and subcapsular location, the patient who had previous history of TACE, surgery, or hepatic artery occlusion may develop an extrahepatic collateral artery supply the tumor. On the CTHA, if you find incomplete enhancement of the whole liver or the whole tumor, you should be suspicious for an extrahepatic arterial feeder in that area. Another clue is when you find incomplete lipidol staining within a tumor mass after embolization. That area might be supplied by non-embolized extrahepatic branch. In this case, the patient has large subcapsular tumor in right lobe, previously embolized with TACE for 3 times. On the diagnostic CT imaging, we found the residual viable tumor with arterial enhancement at the right posterolateral aspect of this mass. However, on CTHA of the hepatic artery, you cannot see any enhancement in this area. After searching for many possible branches, finally we find the parasitic supply from the 9th right intercostal artery. Then we can perform selective tests successfully. Sometimes, if you do not sure whether this nodule supplied by extrahepatic collateral artery or not, you can perform catheter-directed CT angiography of the suspicious branch, such as in this case, the vascular supply from colic branch is not well appreciated on the SA image because of the bowel movement and lipidol staining from the previous embolization. After we confirm the tumor enhancement from the colonic branch, then we super-selective catheterization close to the tumor as much as possible to avoid the colonic wall enhancement and complication. When the tips of microcatheter in the proper position, then we make sure again by run another catheter-directed CTA and perform TACE embolization at this point. Catheter-directed CT angiography can help you differentiate abnormal tumor enhancement from the normal organ enhancement. On left inferior phrenic angiography, the staining you see is not the tumor staining, but actually is an gastric wall enhancement from accessory left gastric branches. Another reason of incomplete enhancement of the liver on CTHA is that the patient might have accessory branch of hepatic artery. In this patient, we found incomplete enhancement of left lateral segment. We almost missed the feeding branch from accessory left hepatic artery arising from gastrohepatic trunk because the gastrohepatic trunk apparent origin from the aorta. The last advantage of an IVR-CT is at the end of the procedure, you can perform non-contrast enhanced CT to see the completeness of lipidol staining within the tumor and also look for the possible complication. In this case, after we perform selective tests via branch of left hepatic artery, post-embolization CT scan show incomplete lipidol staining. The defect is in the anterior part of the tumor. We have to look back at the CTHA image again and try to identify which artery that has not been embolized yet. After we find that vessels, we do selective embolization to complete the procedure. This patient has large multinodular tumor in subcapsular region of left lateral segment. Even though we perform aggressive embolization via extrahepatic collateral of left inferior phrenic artery, splenic artery, left gastroepiploic artery, and also left hepatic artery, on the post-test CT scan, there is still small lipidol staining defect as the posterior part of the tumor. So we review the image and run the post-embolization angiogram again and find that the residual arterial feeder is the collateral from the pancreatic magna artery. Post-embolization CT scan in this patient showed good lipidol staining of the tumor, but there is an abnormal lipidol staining around the wall of common hepatic bile ducts. This finding alerts the possibility of infection and bile duct stricture from the procedure. The possibility of an inadvertent embolization to extrahepatic organ is increased when you perform extrahepatic collateral artery embolization. But if you can identify an abnormal lipidol staining immediately after the procedure, then you can well prepare for the possible complications. IVR-CT can facilitate Y90 radioembolization in many ways. It is well known for partition model dosimetry calculation. It can help detection of extrahepatic enhancement during the workup procedure, and also it can help for extrahepatic collateral artery embolization in advanced cases. For example, this patient has been treated by TACE for several times and was sent for Y90 radioembolization. On workup angiogram, we found extrahepatic collateral artery from right intercostal artery and also phrenic artery. The right 10th intercostal artery supplied the significant amount of tumor at right hepatic dome. We carefully super-selective catheterization deep into the upward portion of the feeding artery. After we are satisfied with the position of microcatheter, then we run the catheter-directed CTA at this point to ensure there is no enhancement outside the liver in order to avoid cutaneous and muscular complication. Eventually, we can treat this patient with radioembolization for all three branches, including right intercostal artery, without any complication. This is a good example how IVR-CT can help you treat extrahepatic collateral artery with radioembolization safely and confidently. In this case, the patient has huge liver tumor presented with dyspnea due to compressive lung atelectasis. On angiogram for Y90 workup in this patient, we deliver technetium 99 mmAA via anterior branch of right hepatic artery, medial branch of left hepatic artery, and also right inferior phrenic artery. The report of lung shunt in this patient is about 4%, so we plan to treat all branches with radioembolization. However, during the review image for those calculations, we found an abnormal radioactivity in the right basal lung. After carefully review the CT study during the Y90 workup procedure, we finally summarized that the abnormal radioactivity in right basal lung is likely from the phrenic artery that anastomoses with pulmonary artery in the atelectatic right basal lung. So we cancel the treatment for radioembolization of right phrenic artery. My last case example for today is the hepatic angiogram during Y90 workup. The patient has the large infiltrative tumor in the left hepatic lobe. We can identify one accessory left gastric branch, so we put coil embolization to that branch, and then we perform CTHA of left hepatic artery. However, on CTHA, we still find myogastric wall enhancement, which likely to supply by tiny gastric branch directly from the liver capsule. In this situation, It likely to be contraindicated for Y90 radioembolization due to gastric wall uptake. In order to occlude tiny gastric branches, we decide to perform partial embolization of left hepatic artery with a large-sized particle. CTHA after embolization show disappearance of the gastric wall enhancement, and then we perform technetium-99 MMA injection at this point. SPECT-CT scan shows no evidence of radioactivity at the gastric wall, and this patient finally underwent radioembolization. In summary, the advantages of IVR-CT are extraordinary, but they come with the price of high capital cost, time-consuming, and add-on radiation dose to the patient. So you have to look through all scan images carefully and keep learning to get the most benefit out of the IVR-CT. Thank you for your attention.